Assalamualaikum and a very good afternoon. To our speaker, Prof. Dr. Peter McCluskey from Safe Sight Institute at Sydney Eye Hospital, Dr. Shelina Mohamed from Hospital Shah Alam Selangor, and our moderator, Dr. Ayesha Muhammad Zain, Hospital Universiti Kebangsaan Malaysia, Kuala Lumpur. Dear all participants, welcome to the Uveitis course, Fundamental of Uveitis. I am Dr. Atikah binti Asini. On behalf of our organizer today, humbled and honored by your presence in attending this course. We have lined up for you to be fruitful and engaging. Before we start, there are a few housekeeping messages that we would like to remind. All participants are required to mute their microphone and turn off the camera, except the moderator and speaker. Q&A sessions will be after each presentation. You may key in your questions using the Q&A icon of Zoom or through Facebook live chat throughout the webinar. A Google feedback form will be emailed to all participants at the end of the session. Please fill in the feedback form by 12 p.m. on Sunday, 30th of August 2020. The e-certificate will be sent to the email address in your registration after the feedback form is written, duly completed. CPD point will be provided for this webinar, and this webinar is being recorded and will be uploaded to UKM Facebook page for future viewing. Kindly access our main page for any subsequent webinar events. Without further ado, I would like to introduce our moderator today, Dr. Ayesha Muhammad Zain. Dr. Ayesha graduated from the Faculty of Medicine, International Islamic University Malaysia, and completed her postgraduate studies in ophthalmology from Universiti Kebangsaan Malaysia in 2017. She was a general ophthalmologist in Hospital Tengku Ampuan Afzan Pahang, and due to her passion in teaching and research, she just recently joined Universiti Kebangsaan Malaysia as a clinical lecturer in ophthalmology. Dr. Ayesha has a special interest in uveitis and medical retina as a subspecialty. So I would like to invite Dr. Ayesha to moderate the session. Thank you.
Thank you, Dr. Atikah, for your kind introduction. Welcome to our third UKM Ophthalmology webinar series entitled Fundamentals of Uveitis. I would like to share with you our program for today. First lecture will be given by Professor Dr. Peter McCluskey, entitled Approach to Understanding Uveitis for Trainees, followed by Q&A session. And the second lecture will be given by Dr. Shelina, entitled Pearls and Pitfalls in the Diagnosis and Management of Uveitis. Without further delay, we are pleased to welcome our renowned guest speaker, Prof. Peter McCluskey. Prof. McCluskey is the Director of Safe Sight Institute at Sydney Eye Hospital and Professor of Clinical and Eye Health at Faculty of Medicine and Health at the University of Sydney. Prof. McCluskey has vast experience of more than 30 years in the field of uveitis. He is very actively involved in clinical research and trials, and he has received numerous distinguished awards from for his contribution from AAO, RANSCO, and also APAO. And today he will be sharing with us on approach to understanding uveitis for trainees. And over to you, Prof. McCluskey.
Great, thank you very much. I will just I'll just share my screen. Okay, can you see my screen okay now? Yep, great. All right, well look, I'll get started. So look, thank you very much for asking me to be part of this session. I'm really excited to see my friends from Malaysia and particularly to work with Dr. Shelina on this program. So what I'm going to do is I'm going to concentrate on how to sort out a patient and go through step by step the way that we sort of sort out someone when you see a patient, you think, gosh, I've got absolutely no idea what's going on here. And then Dr. Shelina in her presentation will start to show you how to apply this sort of knowledge to work out what's going on. So I'll start by just reminding you that the SUN collaboration, the standardization of uveitis nomenclature, has done us a great favor over the past 15 years as they've sort of labored to put together a common language and classification criteria for 30 different, well, it's actually 25 different recognizable forms of infectious, systemic, and isolated uveitis. And the manuscripts for this, I'm part of the group that's working on submitting 26 manuscripts to the American Journal of Ophthalmology, where hopefully they'll be published in a single issue. And it will go through each of these disorders here on the slide and give you the basic criteria that you need to diagnose these diseases. But it's a simple sort of system that we've used, an anatomical classification into anterior, intermediate, posterior, and panuveitis, and then whether it's infectious, part of a systemic disease, or isolated to the eye. And the perfect example of that is sympathetic ophthalmia, a bad disease, but completely isolated to the eye. So just to give you a flavor of what sort of spectrum of uveitis patients we see, these are some old figures from my clinic at Sydney Eye Hospital. And as you can see, without looking at the specific figures, anterior uveitis, even in a tertiary referral unit, is still the commonest form of uveitis that we see. Intermediate uveitis is the least common, and posterior and panuveitis, we usually sort of link them together, and they're about 30% of the diseases that we see. Now, obviously, these percentages will vary depending where you are, and there's a very good series of articles that was in OII back in 2017 that looked at the pattern of uveitis around the Asia Pacific. And just to show you what sort of causes of uveitis we see from my clinic, as you can see, about half the time it's what we often call idiopathic, but is really undifferentiated uveitis. Most of the time we can't identify a reason why, but we do see Fuchs cyclitis and a whole range of ocular syndromes, all the white dot syndromes basically. Inflammatory disease is about 30% of the patients in my clinic, and that's predominantly B27 related disease, but also sarcoid, Behçet's, and a range of other diseases. When you look at infective disease, herpetic infection is the commonest by far, mostly anterior, but there are a very important group of posterior segment herpetic infections. TB is an increasingly diagnosed and recognized disorder, and certainly given the sort of the ethnic diversity of the population in Sydney, it's a common cause of infectious uveitis that we see. Toxoplasmosis, still very important and common, and we must never forget syphilis. And most of the syphilis in my units managed in our acute service and doesn't really get to to our sort of chronic uveitis clinic. So, 40, 38, 37, pretty much equal between TB, toxo, and syphilis. So let's talk first about anterior uveitis, which, as I said, is the commonest form of uveitis. It's basically defined as inflammation that's centered around the iris and ciliary body, as you can see, classically anterior chamber cells, but also very commonly spill over into the anterior vitreous. By far most commonly, it's episodic and recurrent, that is acute anterior uveitis, but it can be chronic and persistent, and there is a fairly wide range of potential causes. So just to remind you about the sort of clinical phenotype of acute anterior uveitis, it has a sudden onset, limited duration, classically less than around 8 to 10 weeks is the duration of an episode of anterior uveitis. The patients present with symptoms. They get a red eye, it's photophobic, it's painful, it can be even tender to touch. And patients who get recurrent disease, they get very stereotypical symptoms. So they can usually tell, sometimes even before you can see signs of inflammation, that they're getting an episode. The signs of inflammation are in this bottom slide here. Cells that you can see in the anterior chamber flare. There can be fine KPs. There's often profound breakdown of the blood aqueous barrier. So you get fibrin, you'll get synechiae, and you can get enough cellular infiltrate that there can be a hypopion. And of course, the fundus needs to be normal. We know that 50% of the patients, certainly in my community, are B27 positive, and around half of the B27 positive patients have a systemic association, another B27 disease, classically ankylosing spondylitis, but it can be psoriatic disease, inflammatory bowel disease, or reactive disease. Very importantly, recurrent acute anterior uveitis is usually a fairly self-limited disease with a good prognosis. By contrast, chronic anterior uveitis is a different sort of phenotype. Insidious onset, it's persistent. The patient usually just complains of blurred vision. They don't have those symptoms of acute attack. The classic sort of group of disease that causes chronic anterior uveitis is JIA. And as you know, these patients often don't present until they've got very advanced disease like a mature cataract. Patients can have a broad range of complications such as synechiae and cataract, raised intraocular pressure and CME. And they obviously also have flare in cells and often will have granulomatous or mutton fat type KPs. Overall, once you get outside JIA, systemic disease is uncommon. So how do we sort out a patient where we think, oh gosh, this patient's got anterior uveitis? So it's a clinical process. That's the first important thing. It's based around taking a comprehensive history, very carefully examining each eye, and very importantly, performing a systems review to try and pick up symptoms that would clue you into there being an associated systemic disease. And the most important sort of things to ask about in a systems review are inflammatory back pain, joint pain, skin lesions, mouth ulcers, a triggering infection, family history of B27 disease, and a sexual history that might clue you into a diagnosis of syphilis. And so the key thing is we usually start to take the history, start to examine the eye, do the systems review, and then we'll go back and ask more questions in the history. One of the important things that I'm trying to do when I'm talking to a patient with anterior uveitis is work out the pattern. Is it unilateral alternating disease, typical of B27 related disease? Is it strictly unilateral? That always makes you think of herpetic disease. B27 disease can be like that, but you always think about herpetic disease. If it's unilateral and chronic, then you might think of Fuchs, cyclitis, or JIA. And certainly if it's bilateral and chronic rather than bilateral and acute, we always must think about JIA and increasingly about TINU, which is the more you look, the more you find for TINU. So just to remind you briefly about inflammatory back pain, it typically presents in younger people, it's persistent, and the characteristic pattern is it's worse at night, worse at rest, and typically wakes the patient up from their sleep early in the morning. They have early morning back stiffness that lasts usually for at least 30 minutes, but often an hour or more, and the back pain improves with activity and exercise. And it's really the antithesis of mechanical back pain that gets better with rest and worse with exercise. These patients are often being diagnosed with an extraordinary number of weird and wonderful diseases. But when we see a patient with anterior uveitis and this sort of a history, we think refer to a rheumatologist to rule out a spondyloarthritis. So when you examine someone with anterior uveitis, the signs are largely non-specific, but there are a couple of very important points to remember. KPs and the iris and the pupil, and I'll show you in a moment, can be some useful clues to the diagnosis. But the most important pearl and a critical take-home point is that unless you've examined the fundi and you know they're normal, you can't make a diagnosis of anterior uveitis. And, you know, we see a regular stream, fortunately not too frequently, but a regular stream of patients who were thought treated and started to be treated for anterior uveitis, who have acute retinal necrosis or have metastatic endophthalmitis or have toxoplasmosis, because no one looked in the back of the eye or they couldn't see the back of the eye. So the things that I always look for, the moment I see KPs, the first thing I do is draw an imaginary horizontal meridian and look to see if there are KPs above the horizontal meridian. Because if there are KPs in the superior half of the cornea, it's usually either Fuchs or herpes or some form of herpetic uveitis. And, you know, classically, herpes simplex, you'll see KPs clustered around an old disciform or an active disciform. You might see this with zoster, but there's pretty much always KPs above the horizontal meridian. Most of the other diseases, or just in fact about all of them, the KPs are down here below the horizontal meridian and classically in Alt's triangle, like this patient of mine with Tinu. So that's the second important point to remember. The third area and the third thing I always look for is I have a very careful look at the iris stroma. The key thing that you want to look for is either sector or more diffuse, as you can see here, iris pigment epithelial atrophy. Sector atrophy is a really important sign that this is likely to be herpetic anterior uveitis. If it's isolated to a sector, it's most commonly herpes simplex. If it's more diffuse, it's more commonly herpes zoster, but there are no hard and fast rules. CMV anterior uveitis does not damage the iris pigment epithelium. It can cause some anterior stromal atrophy, similar to that you see in Fuchs cyclitis. But Fuchs is the other common disease where you look at the iris stroma. Occasionally there'll be really obvious heterochromia as well, but that's a late sign. But Fuchs is an important disease, and the KPs, normal pupil, no iris pigment epithelial loss, that's Fuchs. Whereas an abnormal pupil, often fixed and dilated with iris pigment epithelial changes, that's herpes simplex or herpes zoster. There are lots of tests that you could do, and people often say that in the first episode of anterior uveitis, you actually don't need to do anything, but that's wrong. Basically, every patient must have their syphilis serology done. There's no reason not to test for syphilis in patients with uveitis. I like to get a chest X-ray on all my patients with uveitis. If I'm worried it's herpetic, I'll do an aqueous tap. If they've got inflammatory back pain, or if it's alternating recurrent disease, I'll do a B27, because that helps me to be comfortable I've got the right diagnosis. But the other critically important thing to do is a careful review of systems. Because basically what we're trying to do is, through our clinical assessment of history, examination, review of systems, is either make a syndromic or a systemic diagnosis, or decide that we'll need to do some selective investigations from that list to rule out specific diseases like syphilis. And because basically the fundamental process that we're trying to do is work out what's the cause. Is it infective, inflammatory, or neoplastic? And what's the baddest, most acute threat to vision this could be, because that's what we've got to treat urgently to make sure this patient doesn't lose vision. Now, fortunately, with anterior uveitis, 90+% of the time, that's topical steroids and atropine. More severe disease, we might need periocular steroids or systemic steroids. For chronic disease or frequently recurrent disease, oral methotrexate may be needed, or you may consider using a biologic. So that's basically what I wanted to cover with anterior uveitis, and I'll spend the rest of the time, and if someone lets me know if I'm going way over to make sure I stop, that would be terrific. But basically, intermediate, posterior, and pan-uveitis, I'll talk about together because you need to sort them out as a group. And although they're less common, their vision loss is far more common, because they involve the sort of retina, the optic disc, the macula, retinal vessels. So very important group of disorders. And there can be a sort of an emergency group of presentations, patients that present with a sudden onset and patients who present insidiously. And again, it's a clinical process that we need to go through: history, systems review, and a careful ocular examination. And the key thing that we're trying to do is pick up a pattern and recognize a pattern of signs that will allow us to narrow the differential diagnosis. And you'll know from reading the books and that there's this enormous number of labels that you can use. And we will get to making one of these sort of labeling diagnoses. But the way you start is by looking at the clinical signs. So we look at the blood vessels, we look at what the pattern of changes look like and where they are, retina, choroid, whatever, and are there spots and scars that we can use to make a pattern. So let's quickly look at the blood vessels. So there can be focal little areas of cuffing around a retinal blood vessel, what you might call candle wax drippings, like you might see in sarcoid. There can be arterial sheathing, lots of retinal hemorrhages, signs of ischemia that you might see, for example, in Behçet's. There may be cotton wool spots, like you might see in an arterial microvascular disease like lupus. There can be just vascular occlusion, like you might see mimicking a central retinal vein occlusion, but this is an inflammatory vein occlusion, so related to uveitis, or you might have a macular star, a leaky ocular disc. All of these sorts of things will help to clue you in as to what's going on, because although venous retinal vasculitis is very common and not a very disease-specific finding, it always makes you think of these sorts of diseases: Behçet's, sarcoid, syphilis, toxoplasmosis. Arterial or combined arterial and venous sheathing is much more useful because that does narrow your differential diagnosis down. And the most important diseases to always think about are Behçet's, herpetic retinitis, our old friend syphilis, of course, that we can never forget. So when there's a lot of vascular inflammation, it always makes me think about Behçet's, about TB, and about viral retinitis. This is just a good example of how bad vasculitis can be. This is a patient with TB-related occlusive retinal vasculitis. And this shows you how advantageous an Optos wide field image is, because normally we would only be looking at this little bit around the posterior pole that's relatively normal. But look at the widespread occlusive retinal vasculitis that you can see in this patient. And certainly in our clinic, occlusive retinal vasculitis like this is usually either TB related or Behçet's. We rarely make another diagnosis, but it's really important to clue you in to TB, Behçet's, and obviously syphilis. So the next thing after we've looked at the vessels is we look to try and figure out, where is it? Is it in the retina, as you can see here with this patient with CMV retinitis? Is it not really possible to tell because it's just way too hazy? Is it under the retina in this patient with choroiditis and optic disc edema and probably some form of retinal disease as well? Here's, quite a hot eye with a lot of retinitis and the leakage of protein out of the retina into the macula. So what we're looking for, is it diffuse? Is it a large area like this? Are there multiple areas? That helps to clue us in. And where is it? Retina, choroid, or everything? So retinitis, if you can make a confident diagnosis of retinitis, that's really useful and really important, because as you can see here, this is the next pearl. Retinitis is mostly caused by infection, typically toxoplasmosis, herpes virus, as syphilis, or Bartonella. Obviously, Behçet's is the non-infectious cause that we always need to think about. But when you see this, you're always worried this is toxoplasmosis. This could be ARN, but it also could be syphilis. It also could be toxoplasmosis. Can't really be sure. In the choroid, yes, it can be infectious, but it's more commonly tends to be inflammatory. It can be sarcoid. It could be one of those white dots like this patient here with AMPI. We need to always think that if it's metastatic bacterial or fungal infection, that typically presents initially in the choroid, might be an abscess like this underneath the retina. TB can be a tuberculoma or a multifocal choroiditis, and more diffuse choroidal and RPE involvement and retinal involvement can be lymphoma. And if you've got everything inflamed, so a really hot eye, large areas of peripheral retinitis, this is the sort of thing that you can see in acute retinal necrosis. Here's an inflammatory cause with serous retinal detachments, hot disc, hazy media, VKH disease. The other area and thing that we look at when we're assessing patients with posterior retinitis is we've looked at the vessels, we've looked at what levels are involved. So we look to see if there are spots and scars. So this, I hope most of you would recognize as an old toxoplasmosis scar and a reactivation. The sort of thing that you might see, that you do see rather, in multifocal choroiditis and pan-uveitis, the sort of thing that classically sarcoid can give, or if they're peripheral, what we tend to call Dalen-Fuchs nodules, sort of thing we might see in resolved VKH disease or sympathetic ophthalmia. These more subtle, non-pigmented spots radiating out from the disc. This is the sort of thing that we'll see in birdshot rather. But there are other patterns that we see in other white dot syndromes. And you need to sort of start to think about how to recognize those patterns of spots in the back of the eye. Because basically, to work out what's going on in these patients, again, as I've labored the point, it's the history, the examination, the review of systems, trying to recognize a pattern that we can see. And importantly, to work out, is this likely to be infective, inflammatory, or could it be a neoplastic disorder? And what's the worst, most acute threat to vision this could be? Obviously, in the back of the eye, that's usually an infection. And so, as I said earlier, these patients can present as an emergency, classically rapid onset of severe vision loss and severe uveitis. Typically what we see in our emergency department on a Friday night, because the patient's been letting it get steadily worse or been misdiagnosed with something else. And finally, about 2 o'clock on a Friday, whoever's looking after them says, you better go to the eye hospital. And we'll talk about how to sort these out in a moment. But obviously, there are some of these diseases that present acutely, things like toxoplasmosis, and there are other, or a CNV in a patient with PIC or multifocal choroiditis involving the macular region. But there are a lot, typically birdshot, serpiginous, that present quite insidiously. The patients may be well, they may have had no previous problems, but sorting this out is a clinical process. And so we go back to first principles, take a comprehensive history. You've got to remember that a lot of our patients think that we're somewhere between dentists and opticians rather than doctors. So they don't necessarily tell you that they've got sarcoid or that they've been traveling or, about their sexual history or that they've had a kidney transplant and they're on immunosuppressive drugs. So we sometimes have to go over this time and time and time again to tease out the important things in the history. And that's why we often will start to take the history, examine the eye, and then go back and take more history. And again, as I showed you with anterior uveitis, we're trying to look at a pattern. Is it unifocal, where it's likely to be toxoplasmosis? Could be placoid syphilis, might be a single focus of Behçet's retinitis. Is it diffuse? Is it herpetic retinitis? Is it misdiagnosed toxoplasmosis that's been treated for something else? Is it, severe Behçet's? If it's in the choroid and diffuse, is it VKH? If it's multifocal, is it one of the so-called white dot syndromes? Or is it a tuberculoma or metastatic endophthalmitis, endogenous endophthalmitis? Could it be a metastasis? They're the sort of things if it's a single focus in the choroid. So to try and sort this out, again, there's a zillion different investigations that you could do. And I'm not going to talk about these investigations because we don't have time, but I am just going to remind you about what a fabulous improvement there's been in our ability to get really good multimodal ocular imaging. And that's really revolutionized how we in my clinic and my colleagues and team sort out our patients with posterior and pan uveitis. Wide field digital imaging and wide field fundus autofluorescence is fantastically useful, as is wide field combined fluorescein and ICG angiography. Getting, you know, infrared images and as well as fundus autofluorescence can also be quite useful. And of course, you can't forget OCT, which again has revolutionized our ability to determine the level of the disease and its activity. And occasionally in sorting out uveitis patients, typically birdshot or azure, we will use electrophysiology and electrodiagnostic studies. So I want to finish by just quickly going through this sort of Friday night special. That patient that comes in as everyone's running out the door and you as the registrar are sitting there thinking, I have absolutely no idea what's going on. There's this red hot eye full of cells. You can only get a hazy view of the back of the eye. There's something going on in there. How the heck am I going to work this out? So the key thing is to have this differential diagnosis in your brain. Is it herpetic retinitis? Could it be infective endophthalmitis? Is the patient on anti-VEGF therapy? Have they had cataract surgery? Have they had trauma? Have they had dental work? Have they just come out of ICU, you know, where it's likely to be endogenous? Syphilis, we've always got to think about. In our parts of the world, we've always got to think about tubercular uveitis, and we must never forget that toxoplasmosis can present with a really hot eye, and then the only non-infectious one really to think about is Behçet's disease. Occasionally, well, VKH doesn't present acutely, but it's bilateral, whereas most of the others here are unilateral, and we can never forget drug-induced uveitis, but it's pretty uncommon these days. So sorting this patient out, it's all about the history. So if metastatic endophthalmitis, if you can't tease it out in the history, you won't make the diagnosis. In my part of the world, certainly tubercular uveitis is usually a migrant or someone who's lived in an endemic area. Syphilis, we test everybody for syphilis, but you can often tease it out in their history that they're men who have sex with men, they haven't been using condoms, a whole range of things, but it often takes a long time to tease out that history. Herpetic retinitis is typically the perfectly otherwise well individual who just presents with a terrible hot eye and peripheral retinitis. The other group we see are the organ transplant patients, typically in our community, renal transplants, occasionally liver transplant patients. And they get this a long time after they've had their transplant, and it's a sort of a duration-related complication. Toxoplasmosis can occur in anybody, and obviously Behçet's disease, mouth and genital ulcers, and sometimes coming from the Silk Road ethnic background is useful. The other key thing in sorting these out is the lesion in the retina, or is it something that's come through from the choroid? If it's in the retina, it's usually herpes, toxo, or syphilis. If it's in the choroid, it's typically metastatic endophthalmitis or TB. And this is where an OCT and an Optos wide field camera can often give you very, very useful information. An Optos will often get through and give you a useful image when you're unable to see that. So because it's by now 8 or 9 o'clock on a Friday night, and you've got to think this person could have an infection. What's the baddest infection this could be? What's going to send this patient blind by Saturday, Sunday, or Monday? And that's usually either herpetic retinitis or metastatic endophthalmitis. Sometimes it's toxo. But so what you've got to do, if you can't make a specific diagnosis, which we usually can't on a Friday night, what we do is that we collect some vitreous so that we can send it off for PCR, for toxo PCR, so that we collect blood to do a quantiferon gold if we can, and much more importantly, to do the syphilis serology. And then we inject broad spectrum antivirals, antibiotics, and antifungals, start systemic antivirals, start systemic antibiotics if we need to, start systemic antifungals if we have to. And then if we need to, we can start to use some steroids. But this is the key step, the tap in and inject. And, you know, it is an intense procedure. We usually block the patients to make it tolerable, and it requires quite a setup to do. I would encourage you to check all the drug doses from our pharmacopoeia, which is available as a free downloadable app for your iPhone or for your Android device. And that gives you all the instructions on how to draw all of these up so that you can give the injections safely. So basically what I've tried to do is take you through some of the major points of the clinical process of making the diagnosis, thinking about what you need to include or exclude in your differential diagnosis, making sure that you think about, could this be an infection or is it inflammatory, and making sure that you treat acutely the worst, most acute threat to vision, which obviously is usually an infection. And these are the other critical take-home messages. Very, very importantly, unless you've seen normal fundi, you can't call it anterior uveitis. Retinitis is most commonly infective. Essentially, every patient needs their syphilis serology done to exclude that as a cause. We know that in my clinic, 1% of the anterior uveitis and about 10% of our posterior and pan uveitis is due to syphilis. And very important that you understand how to treat those really hot acute eyes with rapidly progressive vision loss. So I'll stop there. I hope I didn't go too far over.
Okay,
I'll stop sharing my screen.
Okay, thank you so much, Prof. McCluskey, for the outstanding lecture. So now is the Q&A session. So we have a few questions over here. Okay, first question to Prof. In terms of investigation, would Prof include aqueous tap as first-line investigation or spare and tailored according to the most probable differential diagnosis?
Yeah, look, I guess I tend that in a patient that we see in our clinic with acute anterior uveitis, basically the only two tests that every patient gets is syphilis serology and a chest X-ray. And the third thing we get is a systems review. And pretty much all our tests after those two are basically diagnosed on the basis of systems review. So if the systems review looks like inflammatory back pain, peripheral arthritis, the patient's got psoriasis or a history of inflammatory bowel disease, we will usually do a B27. Does that answer the question?
Yes, yes, Prof. Okay, thank you for the answer. And second question, in patient with pan uveitis suspected infection in nature, would intravitreal tap be sufficient for sampling or need combination of aqueous tap or either one is adequate?
Yeah. So if I think someone's got herpetic anterior uveitis, I will do an aqueous tap. If it's someone who's got posterior or pan uveitis and I'm worried that it's herpetic, I will always try to do a vitreous tap. The problem is in children and young adults where there's formed vitreous and you may get a dry tap or you may cause, retinal tears or worse still, a very large retinal tear. In those patients, I will do an aqueous tap. There's about an 80% hit rate of them giving you the diagnosis. But the dilemma occasionally happens when, the anterior tap can be negative, but when you subsequently do a vitreous tap, it's positive. But look, we've just got to do the best that we can. Ideally, I'm going to be giving these patients some intravitreal medication. So I'll try and do a vitreous tap.
Prof, can we decide to do equals or vitreous tap on where is the more inflammation is? It means that if it's more on the anterior, yeah.
Well, look, yeah, I think if there's retinitis, I would always try to do a vitreous tap if I can. If it's just anterior chamber disease, you know, in my clinic, if it's, so I suppose the ground rules I use are if the patient's less than 50, they've got sector iris atrophy, and whether or not they've got corneal changes, that's most likely herpes simplex. If they're more than 60 with age 60 with those changes, sector atrophy or more diffuse iris pigment atrophy, that's usually zoster. And you can't be sure in between. So I will usually only tap those ones if it's important to make the diagnosis. You know, they're an organ transplant patient, so they're likely to go on long-term systemic therapy. The group where we do most aqueous taps for anterior segment disease is CMV disease, because if it's CMV anterior uveitis, we'll want to use long-term ganciclovir gel as treatment. We don't use a lot of oral val ganciclovir, but we use a lot of Vergan gel. So that's when we tend to do the aqueous taps. If there's posterior segment involvement, we will do a vitreous tap if at all possible.
Okay. All right. There's another question from Prof. Shamsia. Why do you call it the Friday night special?
Yeah. So basically, our weekend is Friday and Saturday. Is Saturday and Sunday. So on Friday night, people are running out the door to go and spend the weekend. Or most of our laboratories are closed. You can't get a PCR. We can get syphilis serology on a Saturday or a Sunday. But basically, you know, the consultants disappear. The only person that's left is the poor fellow or the registrar. And there they are sitting in the emergency department on a Friday night while everyone's gone out for dinner or off to see friends. And they've got all these terrible problems to sort out. And what happens is often these patients have been brewing this problem all during the week, and people have been sitting on the fence or thinking it will get better. And then they get scared they're going to be left with this patient to look after on the weekend. So the cells, so we'll send it to the uveitis fellow at the eye hospital. They'll sort it out over the weekend for us. So we actually roster one of our fellows to be on call on a Friday afternoon to deal with the Friday night specials. We usually get 2 or 3.
Okay, all right. So the next question to Prof. Do you suggest that we carry out investigations in all patients with first episode of acute anterior uveitis?
Yeah, I usually do. As I say, I check their syphilis serology. I perform a very careful review of systems. They're the 2 investigations that I do. If it's a sort of if there's nothing on the systems review, I probably wouldn't do much more. My research interest, or one of them, is in B27 related disease. So I often do a B27 determination so I can slot them into my research program, but you don't necessarily have to do that on the first episode. Certainly someone with recurrent acute anterior uveitis, I will usually do that because then I can explain to the patient why they're getting recurring episodes. You know, I can say, look, you've got this white blood cell blood group that we know is associated with having recurring alternating attacks. And we can also reassure them that, you know, we can usually treat these episodes, that the risk of them going blind is low. So you can use that information sort of to help with the prognosis and to tell them how likely they are to have recurrences.
Okay, all right. Next question. What is the first-line intravitreal antiviral for suspected ARN?
Yep. Yeah, so what I do is I use foscarnet because foscarnet covers all the herpes viruses. So particularly if you've got an immunocompromised patient or someone with HIV infection, basically by giving them foscarnet, you've covered them for simplex, zoster and CMV. and it will last 48 hours, and that's often enough time to allow you to get the PCRs done. If we're worried it could be something else, if it's toxo, we might add in clindamycin. But foscarnit's the key medication.
Okay. All right. Thank you. Next question. If you have an anterior uveitis with high intraocular pressure and you just treat with topical steroid and it got better, can you assume that it is not viral uveitis?
Not necessarily, I guess. Often you can't be sure for the first time you see the patient, and you know, like all of these diseases, they tend to evolve over time, and the iris pigment epithelial changes will become more obvious as time goes by. So yeah, I mean, classically, as the person asking the question knows, typically viral anterior uveitis is a hypertensive uveitis, and so a high pressure and AAU is classically viral, but not always. Yeah. So yeah, I think you just got to watch, and you know, time will tell.
Okay, I think this is the last question. What is the criteria of oral ulcer that that give clue towards the diagnosis of Behçet, other than the frequency of 3 times per year? Is there any typical characteristic of the aphthous ulcer?
Yeah, look, often the ulcers occur in crops, so they will have more than one at a time. They're often not only sort of, you know, near the lips, but they'll get them on the tongue, back in the pharynx, well back in the pharynx. So, and they often get, you know, regularly recurring crops of ulcers.
Okay.
But we know most patients with Behçet's have mouth ulcers.
Okay. All right. Okay, I think that's the end of question and answer session. Thank you very much, Prof. McCluskey. Okay, now I would like to introduce our second speaker, Dr. Shelina Oli Mohamed. Dr. Shelina underwent her uveitis fellowship in Moorfield Eye Hospital, London. Upon completion, she served at Hospital Selayang, and currently she is in Hospital Shah Alam. She is actively giving lectures locally and internationally and highly involved in several clinical trials such as Everest 2 and Kite DME as co-investigator. Without further delay, I pass over to you, Dr. Shelina.
Thank you, Ayesha, for the kind introduction. Let me just share my slide. I think I'm not able to share my desktop. Maybe Ayesha, you have to.
We stopped share already, Dr. Shelina. Can you try again?
It's not showing up. I'm not sure why.
Can Dr. Shelina try to share the desktop?
Okay.
Under the desktop. Okay. You have to open your slide.
Yeah.
Okay. 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 Now we can see. You can go to slide share.
Okay.
All right. Okay. We can see now.
Sorry for that glitch. Assalamualaikum and good afternoon. First of all, I'd like to thank Dr. Ayesha and Prof. Shamsa and the UKM team for inviting me to give this talk. It's actually an honor for me to share this platform with our esteemed guest speaker, Professor McCluskey, all the way from Australia. So today in my talk, I will be highlighting a few pearls and pitfalls in the diagnosis and management of uveitis. Hopefully my talk would somewhat complement what Prof has taught us earlier from his very informative talk earlier on. And I will be able to share some, illustrate some clinical cases and give some practical pearls in the management as well. So basically, uveitis may be challenging, as we've heard earlier on, right from the diagnosis up to the management. And the diagnosis not only encompasses identifying specific entities and ocular diagnosis, but it includes a vast number of systemic diseases that can further make the diagnosis challenging. And very often, as we see, clinical clues are often overlooked. And sometimes a patient may be seen a couple of times, and then only we start picking up certain clues and revising the diagnosis. So it's also important to understand our local distribution of the disease, as we know that in developing countries like ours, infectious uveitis seems to be slightly more common than non-infectious uveitis. In a small study that we did way back in 2015 in Hospital Selayang, which is our tertiary referral center for uveitis, it was found that about 70% were of infectious uveitis, TB being the commonest. And among the non-infectious uveitis, idiopathic seemed to be the main number, probably because were they really true idiopathic uveitis, or were there some entities that were not picked up? And of course, Behçet's, VKH, sarcoidosis were the common non-infectious uveitis seen. So the first pearl that I would like to reinforce and re-echo what Prof has said is that we need to classify the patient, okay? We need to understand the sun anatomic classification to localize where the infection or the inflammation is. And we need to look at the cause of the disease, whether the patient is presenting for the first time, being an acute uveitis, or if the duration of uveitis has been there for some time. Are we looking at a recurrence, or is this a chronic disease whereby the medication could not be stopped and the patient is dependent on the medication, or there's no period of inactivity of up to around 3 months with disease-free and medication-free to call it a recurrence. And then we need to look into whether this is infection, inflammation, or masquerade. But just one point to make is that sometimes trainees tend to get confused when you see cystoid macular edema. Where do I position a patient with cystoid macular edema? Is it always an intermediate uveitis? Very often we say that intermediate uveitis would have CMO. Well, cystoid macular edema per se is a structural complication of the uveitis, and it's not a defining feature to determine the site of inflammation. As you know, you can get CMO in very severe anterior uveitis. You can it's typical of intermediate uveitis, but not to forget that you can also see this complication in posterior and pan uveitis as well. So just to highlight, CMO is more of a structural complication. Back to what Prof has highlighted earlier on, history is very utmost importance. In fact, it has been said that if you get a thorough and proper history, more than 90% of the time you can clinch the diagnosis. Sometimes you have examined the patient and you see certain signs which makes you go back to ask further systemic history like TB contact, whether the patient had traveled, had been in a jungle, swimming in a waterfall, and so on, and whether there was any recent systemic infection. And a drug history is also important to know what medications the patient is taking, and also pertinent drug history tailored according to the history of his uveitis, whereby you want to know whether this medication, what dosing he's been on, when the recurrence occurred, at what dose the medication the patient was on, and so on. So let's look at a few clinical scenarios. So this is a young lady who presented. She's actually a medical student who was in the Klang Valley studying here, and she complained of blurring of vision and floaters. Her initial investigations were were all negative. And a toxo, the referring doctor had done a toxo IgG, which was also negative, because if you look at it at a glance, you may think that this is a toxo lesion, being a monofocal lesion at the, adjacent to the fovea. But if you look at the OCT here, you can see that the lesion is more choroidal in origin rather than a retinochoroiditis, which you see in toxoplasmosis. And we went back to ask the patient further history. So she gave a history of having a vague fever a few weeks prior. She had gone back to her mom's hometown in Indonesia where she swam in a lake. We went on to do other investigations, looking for other more atypical infections. And her Mohd serology came back very strongly positive. She was, of course, the definitive way to diagnose mellidosis would be through a culture which was not performed. However, she responded very well to IV Fortem for 2 weeks, followed by 6 weeks of Bactrim, and she recovered her vision. So we presume that this diagnosis of posterior uveitis was secondary to mellidosis. In another patient who had this vague findings in the macula, where you can see some hemorrhages, a small retinitis, maybe some cotton wool spots, and a yellowish creamy lesion in the fovea, comes from a patient who was recently admitted for dengue fever. And this is a typical dengue fovealitis that has been described, which carries a negative prognostic indicator. And this patient was given a short course of steroids where the vision improved. However, there was a small persistent scotoma, which has been described in these patients. This case is a 34-year-old HIV positive male who has a very low CD4 count, and he presented with redness in both eyes with discomfort. The first assumption would be to look for all possible causes of infection in a patient who's severely immunosuppressed as this. So the referring doctor had gone on to do look for signs of endogenous endophthalmitis. The taps were done, the cultures were done, everything came back negative, and the hypopion persisted. And then they went back to the history. Upon referral to us, we noted that the patient was on rifabutin for a smear negative TB. And this medication was eventually stopped by the physicians upon our request, and the patient recovered with topical steroids, and we presumed that this hypopion uveitis was related to the rifabutin once we had ruled out all infective possibilities. Okay, so coming to pearl number 3 is to rule out infectious uveitis in all cases. So as we have seen from Prof's earlier slide, I will just reinforce what we have learned. Clues for infection and infectious uveitis could come possibly from a few clinical signs, namely the keratic precipitates, the ones that go all the way up, involving the pancornea. If you see a hypopion uveitis, you would be concerned to rule out an infection. Retinitis, as has been mentioned, is very suggestive of a viral infection in origin. And if you see choroidal lesions, you also would like to rule out infectious conditions like TB and syphilis. So let's look at this case of a 40-year-old gentleman who came during our lockdown during the recent COVID pandemic. This, he claimed, was his first episode. He has underlying epilepsy, is on epileptic treatment, and he has frequent, occasional seizures. Otherwise, he has no other systemic complaints. His presenting vision was 624. He had a hypertensive uveitis on presentation. There was hazy view of the fundus, but a dilated fundus with a BIO examination did not reveal any retinitis. And if you notice here, the cornea, the KPs on the cornea go all the way to the top. There was some suspicious iris patchy kind of atrophy, which was not very clear on the initial photos. And a diagnosis of herpetic anterior uveitis was made. Unfortunately, at that time, our labs were not able to do the viral PCR due to the stress of the COVID tests and so on. And we had to treat this patient clinically as he could not afford a viral panel by the private sector. And his other investigations were negative. We went on to also check his HIV status, which came back positive. The KPs kind of cleared within a week, and we could see that the IOPs also had stabilized, and we continued to complete treatment for a herpetic anterior uveitis in this patient. This is just to show an example of iris transillumination defect that we should look for in these patients. Coming to the next case, is an 11-year-old boy who is actually the son of a nurse in clinic in one of the referring hospitals, who presented with unilateral anterior uveitis with high intraocular pressure. He was initially treated with topical steroids for about 5 months, and subsequently they were able to taper off the steroids. However, upon tapering the steroids, there was recurrence within 1 month and the pressures became uncontrollable. So if you look closely at the cornea here, you can see some endotheliitis, which is typical of CMV anterior uveitis. An aqueous tap was performed and the CMV PCR was positive. The viral load was very, very high, and this patient was diagnosed as a chronic. Why chronic? Because the patient depended on steroids for almost 5 months, and within a month of tapering the steroids, the disease recurred. So we know that this is more of a chronic hypertensive uveitis. And he subsequently, initially he was treated with Valgan gel. It was not working. And we decided to commence him on oral Valgan with co-management with the pediatrics. And eventually his IOP settled. Luckily he did not need any glaucoma surgery. And he was maintained on topical Gen C drops for a long period of time, for at least more than 6 months. So when you see a patient with hypopion, you often think, is this an infection or is it an inflammation? Well, an infectious, there are some clues when you look at the hypopion. For example, if you see a lesion on the cornea, then it's a giveaway. If you don't, probably the ones that heap up in the center could be more of infective origins. Beshes tend to have shifting hypopion, which are very responsive to topical steroids. And the hypopion of a HLA is said to have a more fibrin and decimate folds and swells up in the center a bit. This is just rough clues when you see hypopion. And in a patient with a hypopion, you need to take a thorough history. For example, the patient on the left who had diabetes, poorly controlled diabetes, a recent admission for Klebsiella liver abscess. And when you dilate the fundus, that's why it's very important to dilate and look for the lesions in the posterior segment. You can see this chorioretinal lesion and sometimes you may see loculations on the B scan, which points towards an endogenous endophthalmitis. And on the picture on the right, this is a young lady who presented with hypopion uveitis. You're not sure is this infection or inflammation, but you have a very good clue here on the OCT, which shows a cystoid macular edema, suggesting that it's more of an inflammatory origin rather than an infective origin. However, there are times when things are not that straightforward, and you can turn to performing a steroid challenge, putting the patient on intensive topical steroids and reviewing the patient every 2 hourly very closely, looking for signs of worsening of the hypopion, looking for signs that this could be infection like lid swelling, discharge, pain, or the aqueous becomes more plasmoid, the cells start moving less, you see more fibrin, and an increasing height of hypopion would point towards an infective origin. So just to recap, pills for infectious uveitis, a dilated fundus examination is mandatory, look at the periphery, review the systems. A hypertensive uveitis is highly suspicious of a viral etiology. Check the immune status in zoster patients. Do not ever start oral steroids or immunosuppressants without baseline investigations. Now, sometimes we come about these kind of patients, and no local steroid injections for patients suspected with infections like toxo and ARN, and don't ignore always look for new signs and symptoms while patients are on immunosuppressives. So now we come to the fourth pearl, which is pattern recognition, which is highlighted by Prof as well. It's very useful in posterior or pan uveitis, especially where you tie up together the ocular and the systemic clinical features. This is a patient who presented with unilateral blurring of vision. He has posterior uveitis, as you can see from this picture. He has somewhat which looks like a branch retinal vein occlusion. If you look closely, you can see a few small choroiditis in this patient. And if you look here at the macula, you see somewhat a suspicious stellate-like exudates in a partial star kind of fashion. The optic disc, however, is not hyperemic or swollen. And we proceed to do angiogram, and you can see large areas of capillary non-perfusion, and you can see vasculitis and occlusive kind of vasculitis in the area where the lesion is and also away. And this patient's MEN2 was strongly positive, and he was treated as a case of tuberculous posterior uveitis. This patient, you can see, in this patient, he comes with a posterior uveitis where the disc is swollen. You can see vague choroidal lesions scattered like multifocal choroiditis, and the macula is dull. Looking at the angiogram, you can see some generalized vasculitis in all quadrants, and somewhere at the periphery, you see multiple hypofluorescent choroidal lesions, which are typical of sarcoid nodules, very often seen in sarcoidosis patients. This patient was further worked up for sarcoidosis. You can see the vasculitis is non-occlusive in nature in this patient. You can see the hot disc, and this patient was diagnosed with sarcoidosis with a MEN2 of 0 and a slightly increased level of the ACE, and proceeded to do a HRCT of the thorax. In this young male who came with hypopyon pan uveitis in the right eye and posterior uveitis in the left eye, on further questioning, he did have frequent painful aphthous oral ulcers. Fluorescein was very helpful in these patients. You can see large areas of capillary non-perfusion with vasculitis, somewhat in a ferning pattern. And on the fundus examination of the left eye, where you can see the fundus somewhat in the periphery, you can see these hemorrhagic retinitis patches, which are also typically seen in Behçet's patients. So this patient is diagnosed with Behçet's disease. This patient, a 35-year-old male who complains of blurring of vision in both eyes. You can see traditionally the hot disc in both eyes. On further questioning, once we had examined this fundus, we went back to ask him about tinnitus, and he claims to have had some tinnitus. And on OCT and on examination of the fundus, you can see there's cross-exudative patchy exudative detachment with striation in the macula in the right eye. You can see this illustrated on the OCT, where you see multiple pockets of subretinal fluid, undulation of the RPE, and also the inner layer, irregular surface of the retina, which is typical also for VKH. And a fluorescein angiogram shows the starry night appearance with a hot disc, and this patient was treated as a case of VKH. He subsequently required immunosuppressive doses of oral steroids as well as a second-line agent. Toxo has been shown earlier on by Prof as well, but to get a history, very often we might miss asking the patient whether he's had a similar history in the past, especially when you have the scar adjacent. So this patient had a recurrent history whereby he had a period of medication-free period for more than 6 months. He was stable, and then he had a recurrence of the disease. You can see this monofocal retinochoroiditis, okay, in posterior uveitis, and there is generalized vasculitis, which you can see, maybe it's not very clear, but you can see the vasculitis away from where the location of the lesion is, and this is typical for toxo, where you can see, sometimes you can see chiral plaques, and you can see generalized vasculitis in all 4 quadrants of the eye, if you look carefully. So this is toxoplasmosis, recurrent toxoplasmosis. So we come to the fifth pearl, which is a reminder again that TB and syphilis are the greatest mimickers when you're dealing with a patient with uveitis. We've always been taught to do the 5 basic investigations, which include screening for TB and syphilis in all uveitis patients. An exception may be the occasional first episode of anterior uveitis. However, as Prof McCluskey has highlighted, even this patient should at least get a syphilis screening at the most if it is highly suspicious. And it's important for us to understand the common spectrum of manifestation of TB and syphilis. So just to re-highlight that TB, the diagnosis of intraocular TB is very challenging often. It's very difficult to get a confirmed definitive diagnosis from cultures. As we know, positive PCR, the rate of positive PCR is very low in the testing that we do, especially locally. It's very difficult to get a positive culture from the vitreous due to the small amount that you can take, and very often we use this criteria to give a presumptive diagnosis of ocular TB, where you depend on the positive MEN2. You can couple it with an added IGRA testing to be sure, and TB lesions on chest X-ray are very, very rare when you're dealing with intraocular TB, and we look at the therapeutic response and exclusion of other features. So how does TB present? It can go from all the way from anterior, intermediate uveitis to posterior and pan-uveitis, and even an endophthalmitis picture. So let's look at a few cases of TB, typical TB cases. The one on this top left corner is a young medical officer who works in a chest clinic who presented with blurring of vision, and he had a typical neuroretinitis. His MEN2 was very highly positive of 20 millimeters and it was blistering. He had a granuloma on the disc. He was treated with anti-TB and remarkably improved. His vision improved from 660 to 6.6 currently, his current vision. This is a typical choroidal tubercles you can see in a patient with posterior tuberculosis. This is a patient with tuberculosis posterior uveitis whom we have treated earlier. This patient presented somewhat like the picture that I showed earlier. You can see vasculitis on the angiogram, and the OCT does not, rather than showing a cystoid macular edema, this OCT shows subretinal fluid. If you can see, the fluid is more of the deeper layer subretinally, and this indicates that this is more of an infectious kind of TB, where the patient required commencement of anti-TB. We did not immediately start the oral steroids until later on when the patient developed vitritis, and then we started immunosuppressive doses of oral steroids for this patient. His vision subsequently improved, and he regained back a vision of at least 6/12 or better, and subsequently underwent cataract surgery. This is an example of a patient with eels secondary to TB. A clue is that usually the anterior chamber is quiet, they don't have cystoid macular edema, there's hardly any vitreous involvement in these patients. But when you look at the fundus, you can see, you might probably seeing new vascularization or areas of pre-retinal hemorrhage. And angiogram can confirm the presence of new vessels, and you can see areas of capillary non-perfusion. This is a typical, and the MEN2 and the IGRA test in this patient was positive, confirming the diagnosis of eels secondary to TB. This patient is a serpeginoid-like choroiditis. You can see these patchy choroidal lesions, which are not the typical serpentine kind of picture that you get in the idiopathic serpiginous choroiditis. That's why it's called a serpeginoid-like choroiditis. And this patient had a positive MEN2 and a positive IGRA. He was commenced on anti-TB alone and subsequently developed paradoxical worsening of the TB. He was immediately put on immunosuppressive dose of steroids to control the inflammation, and subsequently everything settled, leaving remaining scars. So these are typical manifestation of TB, intraocular TB. But just to highlight that the diagnostic dilemma is always with the investigations, whereby the physicians sometimes hesitate to start management of anti-tuberculous therapy without some definitive tests. We depend on, usually if you have both a MEN2 and a T-spot or IGRA test positive, it makes the likelihood of, coupled with the typical intraocular TB features, it makes the likelihood twice as high as if you just have one positive test. This is a patient who was referred to us who didn't have such a typical manifestation of tuberculosis. She complained of redness, some discomfort in the eye, and her eye was progressively getting blurry. She had AC cells of 3+. Her MEN2 was only 1 millimeter. And examination showed a hot disc, a hyperemic disc, and she had a large area of exudative detachment. And we couldn't see, vaguely we could make out some blurry, these are images from the initial referring doctor, because by the time she came to us, she had gross exudative detachment and we couldn't really make out what was happening. But from the initial pictures, you can see a suspicious granuloma there temporarily. And this is the initial picture showing some patchy choroidal, multifocal choroidal lesions and some exudative detachment in the macula. OCT done at our center when the patient came, you can see the outer fluid, the exudative fluid. You can see something is going on in the RPE and the choroidal layers. You can see there's some choroidal lesions, vitreous involvement through the vitreous opacities. And the left eye, which appeared seemingly normal, also had some vitreous opacities there, okay? Subsequently, we went on to investigate her. The quantiferon came back positive. And the angiogram, this is the angiogram of the seemingly normal left eye, which showed generalized vasculitis and a hot disc and some early perifoveal leakage, which possibly suggested angiographic CMO or some early choroidal lesions probably. And on the affected, the badly affected eye, you can see some pinpoint area of hyperfluorescence here, gross vasculitis all over. This area is masking because of the exudative detachment. So this is just a reminder of our earlier photo, but the earlier angiogram done in the referring center showed some pinpoint-like hyperfluorescent lesions, coupled with the fact that the patient had vague discomfort of her eye, and the initial B scan and the B scan done in our center also showed some gross scleral thickening, although there was no T sign, and you can see that choroidal granuloma-like lesion showing up on the B scan as well. So this patient was subsequently treated as a tubercular sclerouveitis. She was commenced on anti-TB, and within a week or two, her vision drastically worsened, and we added on immunosuppressive dose of prednisolone with gradual tapering. Eventually, all the lesions dried up. You can see this patchy residual scarring and this pigmentary changes at the posterior pole where the suspicious granuloma and multifocal choroiditis was. And her vision actually improved close to 612 in the right eye, and she maintained good vision in the left eye. So from 360, she improved to about 612. Just to highlight about syphilis again, you need to test for syphilis in all uveitis. In many parts of the world, they have resorted to reverse algorithm testing, whereby they would do the treponemal test, meaning they would do the TPHA or TPPA test first and then proceed to the non-treponemal testing. However, in our local scenario, we are still doing the traditional testing whereby we do the RPR and the VDRL, and only if it's positive, the labs would proceed to do the treponemal testing. So in this process, we might have false negatives, and we need to understand certain patterns of syphilis that can present in the eye. For example, this pre-retinal retinal nodules that you are typically seen in syphilis patients. Look for the systemic palmar rashes and rashes in other parts of the body. This is a slide just highlighting certain typical presentation of syphilis. As mentioned earlier, we can get anterior, intermediate, posterior uveitis, pan-uveitis, and syphilis can mimic anything. However, typically when you see a patient with bilateral posterior uveitis, you might not be able to pick up the subtle multifocal choroidal lesions due to the vitritis. Sometimes they can present with placoid lesions, the syphilitic placoid chorioretinitis. You can pick this up on OCT. They can get optic neuropathy or optic neuritis, the pre-retinal opacities. You can see them clearly if you look into the vitreous, and they sit anterior on the retina, and sometimes they can get chorioretinal lesions. Sometimes they can get lesions that mimic like lesions, retinitis with some overlying vitritis and retinal opacifications, retinal opacities overlying. Okay, this is just to highlight how a posterior placoid lesion looks like. You can see it highlighted in the autofluorescence and also on fluorescein. You can see it on the OCT. Sometimes it can cause some subretinal fluid. This is a patient who had a placoid lesion, which resolved, the fluid resolved subsequently upon treatment. And just to remind you of the prozone phenomenon in patients whereby especially applicable in our setting where we do the non-treponemal test first. Okay, so on screening, if you get a negative VDRL, it is not 100% true. It might be a false negative, especially in a patient who has high high antibody levels of VDRL titers, which are unable to perform the aggregates with the testing antigen, and it will give a false negative kind of appearance. In these cases, you need to tell your lab to dilute the serum of the patient so that you can visibly see the agglutination or the aggregates forming, and this is called the prozone phenomenon. So if you highly suspect a patient to have positive titers, you need to tell the patient to retest again, diluting the serum, the patient's serum. Okay, so this patient, in this patient, a 28-year-old HIV positive male presented to the referring doctor. He had a CD4 count of 174, and he was referred for a left blurring of vision. His initial VDRL was non-reactive, and the TPHA was not done. He was seen, and clinically it looked like a patch of ARN through the vitritis. And with the good high CD4 count, they suspected an ARN, and they treated the patient with intravenous acyclovir. However, on subsequent reviews, you can see initially the patient did not have any lesion in the posterior pole. Subsequently, you can see a lesion, placoid-like lesion appearing adjacent to the temporally, and also the initial ARN-like lesion was increasing in size upon subsequent visits. You can see that it was not responding to treatment. A repeat VDRL titer showed high titers of 1 in 512. The TPHA was positive. This patient was treated as a case of neurosyphilis with 2 weeks of IV benzylpenicillin, and eventually improved, his vision improved tremendously subsequently. Okay. The sixth pearl I come to is, when in doubt, use imaging, which could be the savior. It could save your day. Okay, so as a Prof has mentioned, now we have various multimodal imaging tools which we can use to help aid in the diagnosis. Like earlier on in the patient where we saw who was suspected of toxo, but then when you did the OCT, you know that the lesion was more deeper in a choroidal layer, and it will tell you whether this lesion is in a retina or in the choroid, for example. Okay, I would like to illustrate this young 48-year-old gentleman who had no systemic complaints. He complained to us. He also came during the recent lockdown period during our COVID pandemic, and he just complained of a vague paracentral scotoma. He had no eye pain, no redness, low floaters. It was a very vague complaint. His vision was good at 6/9. The anterior segment was unremarkable. There was no cells. There was no anterior vitreous cells. And when you look at the patient grossly, in fact, from this photo, you don't see anything sinister happening, except for the vague kind of lesion at the posterior pole in the left eye. We went on to do the OCT, and you can see this small bump here on the RPE here. It was just a suspicious choroidal lesion there. He had good vision, and the right eye seemed unremarkable. The autofluorescence seemed not very convincing in the right eye, but in the left eye, you can see that there's something going on, especially temporal to the macula here. It was increased autofluorescence signals there. Subsequently, an angiogram was done. This was the seemingly normal right eye. You can see some peripheral vasculitis in the normal eye. However, there was no hot disc or nothing was going on in the macula. In the left eye, you can see there was some vasculitis. Sorry, this the answer has come out, but well, there was some vasculitis here. And perifoveally, you can see there's some perifoveal leakage, some perifoveal vasculitis, which is really threatening the fovea here. And all this could explain the vague scotoma, paracentral scotoma that the patient had drawn. And it was corresponding to the site of this lesion on his Amsler charting. He was a male, MSM male actually, and on further history, his VDRL was positive and his TPHA was positive. We decided to treat him as a case of neurosyphilis because it was sight-threatening, although his vision was good. After counseling, he agreed, and subsequently all his symptoms recovered, and he regained his vision to 6/6. This is another 21-year-old gentleman who had a recent history of a penetrating injury to the left eye. 2 weeks prior, he came with the right eye blurring of vision. Of course, our immediate thought would be of whether this is a sympathetic ophthalmitis that we're dealing with. This is the right eye vision of 6/9. You can see that the anterior segment did not have any cells. Anterior vitreous also did not have any suspicious cells. All you can see is this subtle hyperemic optic disc, and maybe nothing much sinister going on the fundus actually when you look at the funduscopy here. The OCT also did not tell us much. Okay, there was nothing significant there on the OCT. The optic disc cuts of the OCT showed that the disc was swollen slightly with a little bit of fluid around the disc. And we went on to do an angiogram. The angiogram just confirmed the hot disc that we saw earlier on, but the ICGA was very helpful where it showed the typical hypofluorescent dark dots that you can see, suggestive of diffuse choroidopathy in a sympathetic ophthalmitis. And this diagnosis was made. He was immediately put on high-dose steroids. He was started as well on immunosuppressants immediately, and he was able to maintain his vision, and subsequently over a period of time his symptoms improved and his condition stabilized. He's still on immunosuppressants. He will be put on this for at least 6 months to a year. So now let's come to some of the, once we have heard the pearls, let's look at some pitfalls that all of us might be guilty of, not just, I speak in fact for myself, for my team, and in fact for every one of us who has managed a uveitis patient in the past, okay? So the first pitfall that we often encounter is aimlessly trying to run a whole battery of investigations, hoping to hit a target. And the commonest misfire that one would do would be to look for an ANA, a rheumatoid factor, a leptospira serology, and so on. In this patient, we can see that this referral was made. The patient had cells, he had a unilateral panuveitis, extensive exudative retinal detachment. However, the battery of investigations were done, showed positive ANA. They went on to investigate the ENA, a rheumatoid factor. These kind of investigations are pretty irrelevant in a patient who had a unilateral panuveitis with vitritis. And probably a toxo would be more relevant if you see dense vitritis. So just to remind us not to run a battery of investigations which makes us confused and throws us off balance. The second pitfall is under treatment. Very often some tend to use topical steroids to treat intermediate posterior pan uveitis, which is not adequate. You need systemic steroids, and sometimes tapering too fast or starting immunosuppressants too late are some of the pitfalls that we make. We have seen patients with untreated with intraocular dexamethasone implant. So be careful when you see patients with retinal lesions or suspicious infections. Never give them injectable steroids. In this patient who was immunocompetent and was given injectable dexamethasone, whereby you can see the vitritis cleared, but you can see the progressing lesion. And this patient was a typical Friday night special, an immunocompetent male who came with rapid deterioration of vision in the left eye. He was probably the retinitis was not picked up, and he was treated with IV steroids, which thoroughly worsened the condition. The right eye started developing symptoms and signs. Vision deteriorated. He was subsequently tapped, and a HSV was detected, and he was treated for a case of progressive outer retinal necrosis. And this is how he looked like when he came to us. He lost his vision in the left eye, but somehow managed to preserve some vision in the right eye. So reminder, when you start steroids, make sure you're not dealing with an infection. The other reminder is surgery in a hot eye. Be careful if you want to operate in a patient with uveitis. Make sure the disease is quiescent. Sometimes undiagnosed uveitis inevitably undergo cataract surgery and missing the diagnosis. And sometimes perioperative management is tapered. The steroids, whereby the tapering of the steroids is too rapid, is also a concern. Basically, we would like to have a quiescent eye for at least 3 months. You can inject the patient if it's a non-infectious uveitis, cover the patient perioperatively, and try to use intracameral dexamethasone at the end of the surgery. This is an example of a stormy post-op eye in a young child with frequent relapses post-surgery. And this lady who had bashes in the right eye, who had come all the way from Indonesia to Malaysia with a similar complaint in the past, and she was thought to have endophthalmitis because she had presented with a hypopion uveitis. She underwent an urgent PPV, and subsequently her eye went, she completely lost vision, and the eye became tisical. So a caution when you want to do urgent surgery in a hot eye. The final pitfall would be missing a masquerade. Suspect these in elderly patients with posterior uveitis. You need to rule out infection as well. Look for clues like vitreous cells in sheets. Look for patients who have a lot of vitreous involvement, but hardly, there's no cystoid macular edema. You can see deposits in the outer retina as seen in this OCT. You can see the undulation and some deposits in this outer retina here. They may initially respond to steroid, but then they worsen. The delay in diagnosis can ultimately be life-threatening. For example, in this patient who was referred to us, he's an elderly diabetic who had 2 months blurring of vision. He was initially thought to have an atypical toxo lesion. However, upon starting steroids with the Bactrim, subsequently he noted there were new lesions cropping up and worsening and increasing lesions. This patient was subsequently diagnosed with a presumed primary vitreoretinal lymphoma. The steroids were quickly tapered. He presented to ED eventually with seizures, and MRI brain confirmed a primary CNS lymphoma, and he's undergoing chemotherapy currently. This young lady presented with what looked initially like a bilateral inflammatory uveitis, but if you look closely, she has retinitis as well as choroidal lesions. She has no cystoid macular edema. You can see those outer RPE undulation and outer retinal deposits in her, no cystoid macular edema. This patient actually succumbed to her illness, whereby she was diagnosed with lymphoma, a brain biopsy. She succumbed to the illness as she was performing a brain biopsy, which showed some suspicious CNS lymphoma. This was her FFA, which showed some punctate hypofluorescent lesions that have been described in lymphoma with some phlebitis. And this patient passed away due to lymphoma. So in conclusion, each uveitis requires thorough history, meticulous examination, and targeted investigations and appropriate management. We need to always look for that infectious or masquerade case that we might miss. TB and syphilis are always a possibility, and please be cautious with steroids. Thank you very much.
Okay. Thank you so much, Dr. Shelina, for the lecture and very interesting cases presented. It is time for our Q&A session again. Here, suddenly we have a sudden surge of questions coming. I would like to invite Prof. McCluskey to join our Q&A session. Okay.
Prof.
Okay.
That's a great talk, Shelina.
Thank you, Prof.
Okay, for the questions, in uveitis patients with positive syphilis test, do we consider isolated anterior uveitis as neurosyphilis and treat with intravenous penicillin, or only those presented with optic disc swelling treated with IV penicillin?
Yeah, look, I think patients with isolated anterior uveitis, most infectious diseases or genitourinary medicine physicians won't treat them as if they've got neurosyphilis. Certainly, you know, once the posterior segment is involved, the patient's got neurosyphilis. So, you know, the retina is part of the brain. So if you've got syphilis in your retina or your vitreous or your choroid, you've got syphilis in your brain. The only exception is a HIV patient. Any HIV patient with syphilis, we always get them lumbar punctured and we always treat them as neurosyphilis. Is that what you do, Shelina?
Yes, exactly.
Yep.
Okay. For the next question, in VKH, when do we start second line agent? Is it during first presentation of uveitis with exudative RD after completion of IV methylprednisolone, or later in the if there is relapse? Maybe Prof can answer.
Sure. Look, with VKH disease, we know that they're going to need treatment usually for a minimum of 6 months, often longer. So certainly in my clinic, we would normally work those patients up to start them on an immunosuppressive agent, a second drug, pretty much straight away, because we know they're going to be on treatment for a long time. And obviously, if they've got comorbidities like diabetes or obesity or cardiovascular disease, you know, we will always put them on a second agent. We tend to use methotrexate. So we would just do the standard, you know, work up for a second line agent. So, you know, either a quantiferon gold or a MAN2, Hep B, Hep C, you know, chest X-ray, the usual sort of things.
Okay, thank you. And the third question, what is the B-scan finding in a post-vitrectomized eye with endophthalmitis? Will there be any loculation seen? Maybe Dr. Shelina can answer the question.
Yeah, loculations are quite non-specific findings, and they're quite difficult to pinpoint loculations, even generally in a non-vitrectomized eye, unless it's very obvious. Sometimes what you think a loculation is may turn out to be not, and reverse eitherwise as well. In a vitrectomized eye, it's even more difficult to actually look for loculations, and probably you need to look for other clues to suggest the possibility of endophthalmitis, not just guided by the presence or absence of a loculation. What do you think, Prof?
Yeah, look, I agree. Once the patient's had a vitrectomy, it can be difficult. And also, I don't think loculations, you know, are absolutely diagnostic. It's a bit non-specific. Yep.
All right. Okay. For next question, would cataract surgery after intensive treatment for ocular TB safe, or should we wait until completion of maintenance?
I'm very happy for Shelina to answer that.
Thank you, Prof. I think the most important thing is to control the inflammation in the eye.
Yeah.
Okay, if the patient has not been hasn't completed the long course of steroids, which will go on for 9 months. But the most important thing is to attain intraocular quiescence of the disease. And once it's quiescent for at least 3 months, or as long as you can keep it quiescent, and if the cataract is not too pressing, then you go in for the cataract surgery. But it's okay if the anti-TB has not been completed.
But at least 3 months. You suggest for at least 3 months of anti-TB.
Yep. Absolutely.
Okay. And then another question, in suspected viral uveitis cases, do we do aqueous tap for viral PCR before starting treatment? Yeah, maybe Prof can help.
Usually, yes, that's certainly what we like to do. Unless the patient is immunocompromised, once you start treatment, you very rapidly turn off viral, expression in the anterior chamber. So you can then end up with a false negative test. So depending on the scenario, we will try and either do the tap before we start them on treatment, or wait till they have a relapse and do a tap before we start to treat the relapse.
Okay, all right. Then another question, if vitreous tapping shows mixture of herpes zoster virus and CMV, should we use Intravetro Foscarnet or ganciclovir?
Yeah, look, it's pretty rare, but I have seen a few dual infections.
Mm-hmm.
I've had one in a HIV patient, and I've had at least 3 that I can think of in transplant patients. So that's why Foscarnet is such a good drug, because it treats both the VZV and the CMV. So that I would use intravitreal Foscarnet.
Okay. Next question. Is it prudent to restart another course of anti-TB if there is any recurrence of uveitis in a previously treated presumed ocular TB, which has been quiet for some time? So if there is a recurrence of inflammation in previously treated ocular TB cases, should we start again the anti-TB?
I would also like to ask your opinion, Prof. But to me, what we have been taught is once you have given a course of anti-TB and you completed it, and you get recurrence of the uveitis, that recurrence is more inflammatory in origin, and you usually don't need to restart another course of anti-TB, but more to control the inflammation subsequently, unless you think the features of the uveitis are more inclined towards an infection, like the choroiditis or the infected type of TB that we see. Otherwise, if it's just the inflammation with CMO and vitritis, then you go on to give, even at some point, require immunosuppressants after co-managing with your physicians. When you use steroids, it doesn't control well, then you might need to go on.
Yeah, no, I agree. We would do the same thing. I guess the most important thing is just to be sure that the patient has been compliant and has actually, treated their TB. But we most of the time we tend to do those dots, directly observed treatment to make sure that that's the case. Certainly, you would also, I guess, you could think about where this could be multi-drug resistant TB, but that's still very uncommon in our part of the world outside of New Guinea. So we would just assume it's inflammatory and treat them as inflammation rather than retreating TB.
Okay. All right. Thank you. Then next question to Dr. Shelina. Is there any role of OCTA in diagnosing and treating ocular TB?
Honestly, I don't have much experience with that. Maybe I can ask Prof.
Yep, sure. So exactly what was, just remind me, where the OCTA was in a particular disease or just in uveitis in general?
The question is OCTA in treating ocular TB.
Yeah, I can honestly say I have no experience using OCTA for ocular TB. We do use it looking for CNVs, you know, in patients with PIC and multifocal choroiditis and toxo scars, and it sometimes can be very useful there. But I must admit I have no experience using it for patients with tubercular uveitis.
Okay. Then we have a next question. Should we start hard only after CMV retinitis is treated in HIV patient?
Sure.
So, actually, once we finish the diagnosis of CMV in a patient, HIV patient who has started on hard, we normally tell them to delay the commencement of the because they're concerned about immune recovery with the HIV. But it's not for them, for us to complete the treatment, then probably when the disease has been, we've commenced a few treatments has been given, then subsequently they can commence the heart therapy, laying it a little to prevent the occurrence of IRU. Is that correct, Prof?
Yeah, I agree. And the other thing to do is not to stop the CMV treatment too early. We like to wait till the CD4 count is reliably above 200 before stopping the CMV therapy. Yeah.
Okay, all right. And then next question. For a patient with resolved CMV retinitis, do we have any antiviral prophylaxis prior to cataract surgery?
Shelina, I wouldn't. Would you do anything different?
No. Because usually the CD4s should have picked up by then, and you know, the patient would be on heart.
Mm-hmm. Then should we prime with steroid in this kind of patient? No.
No, no.
All right. Okay. Okay. Next question. When should we perform IGRA test in cases of suspected TB?
Maybe Shelina, you could talk about that the way it is in Malaysia, because in Sydney, you know, an IGRA is really the only test we can get now.
For us, what we normally do is screen with a MEN2, which is the cheapest and really ready available. So once we've got the MEN2 test, and if the MEN2 looks negative, but your condition, the intraocular signs really point towards TB, you would still go on to do an IGRA or TB spot test. But if your MEN2 is already positive and it confirms your suspicion of TB, but if you would like to double confirm, as I showed earlier in one of my slides, if you have two positive tests, the likelihood of it being TB is twice that of a single test, and that will just help you to further confirm. But because IGRA is not an available test, because you have to pay for it, you've got to discuss with the patient. We are moving towards more and more patients who we subject and we ask them to do this IGRA test. It helps us very much. Because as you saw earlier, we have a patient with a MEN2 of 1 and the IGRA turns out positive. Kind of patients.
Okay, I think we have last question here. Is it advisable to commence topical NSAID in anterior uveitis before the results of investigation available?
I don't have a problem starting topical NSAIDs while you're waiting for test results. Do you see that as a problem, Shelina?
Not really, but it just might not be, if it's a very severe uveitis, probably it might not be very effective.
Yeah.
But if you're concerned about an infection, yes.
Okay. All right. Okay. Is there any more questions? There's another question here. In CMV anterior uveitis treated with ointment Valgan cyclovir, what is the percentage to recur and to restart ointment Valgan again? Yeah,
well, I guess the best evidence comes from Professor Chi in Singapore. And in their experience, about about 2/3 of the patients respond to topical Virgan ointment, but a much lower, but in those who respond, it's only a relatively small percentage that relapse. So that if you're a responder to topical Virgan, you have a lower risk of it recurring. My recollection is that it's somewhere around the 30% mark, which is lower than the other drugs. And so what we tend to do in our clinic is get them down to a maintenance dose of Virgan gel, if we can, of twice a day, and we just leave them on it. It seems to be an incredibly well tolerated medication topically, and we just, if we can, leave them on it, and that seems to suppress it. Shelina, what do you do?
Yeah, more or less the same, Prof. But sometimes Virgan is very expensive. So we follow Professor Chi's advice on reconstituting topical Virgan eye drops, which we find can be effective in those patients who don't have a very high viral load as well. So a maintenance of EDS or kind of drop medication for a long period of time, like for 6 months or so.
Right.
Okay, all right. There are a few participants who put up their hands. If they have any questions, you can unmute your speaker and ask question directly. There are about 4 or 5 raising their hands. Is there any questions? Or you can type your question in the chat box. Okay, there's a question here. Can ocular TB presented as retrobulbar optic neuritis? Maybe Dr. Shelina can answer.
Personally, I haven't seen one, but TB can be anything, so it's probably not common. Usually you can see the optic nerve involvement, you might see a granuloma, neuroretinal, but I haven't really seen a retrobulbar case before, but it's not impossible, I think, when it comes to TB.
Yeah, I'd agree. TB can do anything, but I've never seen, sort of a true optic neuritis type picture. Certainly we've seen sort of, meningeal and infiltration and basal meningitis and, sort of that sort of involvement of the optic nerve, but not in a sort of a demyelinating type optic neuritis. But I agree with you. TB is like syphilis. It can do just about anything.
Okay. All right. Okay, in CMV anterior uveitis with high IOP that warrant a tube surgery, what is the steroid regime recommendation pre and post-op?
Do you want to go first, Shelina?
I think you.
Okay. Sure. Look, I think, in the end, it's the glaucoma that's the problem with these eyes. There are a group that get those sort of evanescent, very mild attacks of uveitis, but with very high pressures. And many of those slowly convert over into just becoming a chronic, persistent anterior uveitis. And they sort of can look very similar to Fuchs' cyclitis. So I assume it's those sort of chronic ones that the questioner wants some information about. And the thing is that sometimes you can't ever really completely control them. So you just have to get them as good as you can. And, if the pressure's 40 or 50 or whatever, and you're losing vision, or you're going to lose vision from pressure-related damage, I think you just have to get on and do the surgery and deal with the uveitis, because fortunately, uncommon from CMV anterior uveitis. So I would just get on and do the surgery.
Okay.
Just to add, I think one concern in these patients perioperatively is when you intensify the topical steroids, you need to increase the antiviral to
Yeah,
because
absolutely.
yeah, the viral proliferation. If not, you'll be increasing your viral load. So as you increase your perioperative topical steroids, you push up, correspondingly, you push up the antiviral as well. Don't keep it at a easy dose and increase your topical steroids.
Yeah, I'd agree.
All right. Okay, I think we don't have any more questions. Thank you to Prof. McCluskey and Dr. Shelina for answering such hot questions. I think we already at the end of our webinar. All right. Okay. To our guest speaker, thank you for the outstanding lecture presentation this evening. We are very grateful for the time and effort you took to share your knowledge and experience with the audience. To the audience, thank you for your participation, and we hope this webinar has enlightened you, especially our trainees. And big thanks to our committee members, especially Prof. Shamsia as our advisor for this uveitis webinar. Thank you so much, and till we meet again next time, thank you and take care. Thank you everyone. Thank you Prof and Dr. Shelina. Thank you Prof. Shamsia.
Great. Thank you very much, everyone. It's been a real pleasure, and good to see my friend Shelina and Maylin and everybody, even though it's only virtual. Okay.
Thanks very much for
All the best. Bye-bye for now.
Thank you. Bye-bye.
Thanks.
Thank you, everyone.
Thank you.